I'm really excited to have Dr. Lotta Skoglund, who I got a chance to meet at AppSard, and she has written a book. It's ADHD Girls to Women Getting on the Radar. And you have lots of experience. You're both a psychiatry background, family medicine background, special interest in addiction and ADHD. There's a lot more that could be said, but so happy to have you. You're from Sweden and have done a lot of research and involved in this. So, welcome to the podcast.
Thank you so much. And I'm so happy that we finally got the time zones to actually match and that I actually appeared here at the right time, at the right place, and got the link right.
Yeah, that's awesome.
Yeah.
Can you tell us a little more about your background and how or what inspired you to get interested into the world of ADHD and then specifically girls and women?
Yeah, there are a lot of different, I guess, ways into this interest. But to be honest, when it started back with my background as a GP and in general medicine, because I realized that talking to people was what I liked doing the most, and also what my colleagues seemed to like the least. So it ended up being, talking about life and talking about different problems that you encounter and that you may or may not feel more or less ashamed about. So that's how I got interested in psychiatry and addiction, really. And when I started working at this youth center for addiction, I quite soon got interested in ADHD because there was such a huge overlap and comorbidity. So that's where my research interest actually started. So I started doing my PhD on ADHD and addiction. And when I defended my thesis in 2015 and I needed to look at some other kind of aspect of ADHD, I came across my old friend and colleague from med school, Helena Kopkalny, who was a gynecologist, and we started talking about the patients that we've been working now for 10, 15 years in our field as specialists. And still there are patients that we're concerned about and where we feel inadequate. And she described a group of young women who actually was the perfect description of my ADHD clinic. So we started talking about that and about perhaps you were seeing the same women, but for different reasons. So that is basically how I came to nerd down on this topic.
Yeah, that seems a similar path that a lot of people who have an interest in overlapping conditions where they start seeing these patterns. And like you, I like getting a chance to talk to people and recognize it's a little more than the simple biomedical approach of a simple, here's a blood pressure med, a cholesterol medicine, and asthma medicine to treat things. You have the title of the book, Getting on the Radar. Here's the book right here. And why do we have to get them on the radar? Are they invisible or something?
They're not really, but in some ways they are invisible because we tend to, and we've been doing this for forever in other fields as well, viewing like the man as the norm. So women are basically just smaller men in that context. And knowing what we know today about biology, neurotransmitters, hormones, that is just not a sustainable view anymore. It's hard to defend why you should treat everyone according to the same norm when we are basically two different subtypes of the human species, because hormones are so powerful. They affect so much in our bodies and in our brains. And females have this fluctuating, constantly differentiating situation going on across their entire reproductive life. So I think we miss a lot of important information, and we risk missing out on a lot of important information about female specific symptoms and diagnosis. And also, I guess what we're going to talk about today, symptoms that are heavily overrepresented in women, such as fibromyalgia, for example. So there's more to this than just females complaining a lot. There is things where we can, by looking at it through this lens, understand and also mitigate a lot of what we're seeing. But we're just not doing that because we are ignorant to that. And we're just not interested enough to raise that. And when you do raise that, I find that really interesting, you are considered to be almost an activist. And it's biology. So I'm supposed to be a radical feminist activist for pointing out that biology is a thing here, right? That's
Yeah.
just strange, right?
There's so many different thoughts. One is just obviously diving in, talking about the impact of hormones, that I want to talk about, but just had a recent patient of mine who was seeing a GP, and she went prior to seeing me, and had the GP wanted to go to the route of depression and anxiety. And when this patient had been thinking about in her late 30s, I think I might have ADHD, she said, the doctor shut me down right away.
Yeah.
Didn't want to talk about it and just wanted to go on an SSRI.
Yeah. And I think, unfortunately, this is going to be even more common now since some women have actually come up on the radar. And that seems to be very provocative for many people. So just when the women and girls are actually entering the scene, it collides or is coexisting with our fear of overdiagnosing, and now everyone needs to have a diagnosis. We were not that concerned when the prevalence numbers for the boys and for the males were increasing, but now when the girls are on the radar, this has become a huge problem. And I think also that is really problematic because then healthcare professionals take into that mode saying, okay, so now everyone is seeking out to diagnosis. And that is just exactly the same point where women are actually aware of this and that they may also have been struggling with this their entire lives. So it's a very unfortunate, like, coincidence in time, and maybe not a coincidence, but that is actually what's, as I see it from the outside, is actually happening now. So I do sympathize with what your patient said, and I think she's unfortunately not alone.
Yeah. There's a lot of mischaracterization of what ADHD is and how women are different and girls may be different. And the framework and understanding that, and like you talked about at the conference and just now with your gynecologist colleague, that often we will characterize somebody in the general medicine practice as they are a non-compliant patient. And when I remember being in a resident right before I was finishing, and I had senior residents who had graduated, and they would talk about a lot of people they'd say, oh, there's the worried well. And I never believed in hypochondria. I always put the best construction. That was my framework. I don't think, I know there's schizophrenia when people hear voices that don't exist and things like that, but that was a mischaracterization. And I think that often continues into this, and hopefully conversations with leading experts like yourself can help amplify this message. Let's get into some of the details about first, let's talk about girls and women before menopause.
Yep.
Let's talk about them and what they're like with ADHD.
So typically again, and then again, of course, everyone is different, but typically what we see from epidemiological research and also from our clinical experience is that girls before puberty tend to, on a group level, experience or emote less externalizing symptoms. So they do have a hyperactivity, impulsivity, but they're more often diagnosed with ADD, so the more inattentive form of ADHD. Their hyperactivity, their impulsivity may be more in the form of verbal impulsivity, just interrupting others, talking really fast, talking too much, being like fidgeting with things or things that we're not perhaps primarily used to viewing as a sign of ADHD, where we look at this typical boy who runs around and disturbs his classmates and get kicked out of the soccer practice, or has this more externalizing disruptive behavior. So that is one of the reasons that we think that we miss the girls, because we don't see their hyperactivity and impulsivity in the same way, and maybe also because a larger part of the sample of girls with with ADHD have the ADD form, where there's more inattentive symptoms. So they seem to sit quiet in the classroom, don't disturb anyone else, but also zoom out and don't pick up on the things that they need to actually perform academically. And when they actually try to ask adults in school or talk to their parents about this, we're not, it seems like we're not picking up on their difficulties. And that this is a huge problem, because when they actually do get into the clinics and get to the diagnostic assessment and situation, they're often more impaired than the boys. So that's a huge problem that we have, and a responsibility that we have as adults to actually see these girls and listen to them when they are actually trying to tell us how much they are struggling, and that they see their life as this uphill struggle where they are not liked by their peers, they are not liked and appreciated but by adults. And that is something that has been shown in research. So that is an experience that they have, something that they try to communicate to us, where we unfortunately try to soothe them or normalize this and saying, well, everyone can feel left out, and everyone struggles, and everyone feels stressed out when it's a math test or something like that. But we miss that there's a distinct and different quality to their suffering and their problems. And if we don't listen to that, they will silence, and they will try to solve this in some other way, but they will carry on with this feeling of that they are different and that they're flawed in some way, but also that there's no hope, because no one really has anything to offer to help them, to support them with this. So this is a very lonely experience for many of these girls. And actually, there are research where the researcher have written these vignettes where they describe a typical ADHD boy that has all these symptoms that we are used to looking for, and then they distribute this like story of this boy to parents and to healthcare professionals and to teachers, and they ask these kind of professionals and parents, so let's call him Emil or Amir or something. So Amir, why is he struggling so much? Why do you think Amir has so much difficulties in school and with his peers and everything? And unanimously, parents, healthcare professionals, and teachers say Amir probably has ADHD. So he probably should do an ADHD assessment and be put on meds, right? Because there are effective treatments for this. And that was one side of the story. But the other side, and maybe the more important part of the story here, is that if these researchers just edit out the male pronoun here and exchange it for a female name, say Emilia or something, and would say the exact same story and hand out these vignettes to healthcare professionals, teachers, and parents, and they say, so why do you think Emilia is struggling so much? Why is her life so messy and difficult? Then we start thinking in completely different patterns. So then we start thinking about psychosocial and why she is seeking attention from older guys, and why she is posting all these images on Instagram, and why why there's so much difficult with her female friends, and what's her parents doing in all this, and isn't her mother working too much? And so there are a lot of these now explanations that is in a completely different direction than what we have if the pronoun, if the child described was a boy. So I think that's extremely important to keep in mind, that we are biased because we are actually products of a society where there has been historically very different ways of viewing a girl and a boy, and what is a typical boy and what is a typical girl. And then a typical boy with ADHD will be a typical boy with ADHD, but a typical girl with ADHD will be atypical girl with ADHD. So there is this difference on a societal level even before the biology kicks in. Because when Emilia then enters puberty, then there's another layer of this equation. So then she enters a period of dramatically fluctuating sex hormones every month. So 3 different phases basically in her hormone status, affecting her brain extremely different, affecting her ADHD symptoms differently, and once she is diagnosed, also affecting the effect of her ADHD medication very differently. And again, we go to the male norm. So we treat Emilia just as we treat any other boy, with a stable hormonal level. So you get the same dose, you get the same assessment, you get the same tests, you get the same examples from, oh, do you typically do this or that when we're assessing symptoms and medication effect or everything. So that is yet another like layer and aspect of what it is to be a young woman. And in our research, we have focused a lot on these young women, exploring why they have, for example, 6 times more the increased risk of becoming teenage mothers. They have 24% increased risk of postpartum depression when they actually do become mothers and give birth to children. They have an increased risk for all the obstetric risk factors, for preterm birth. So there's so many things where what we know from solid research that girls and young women with ADHD actually suffer from in this timeline, basically, of their reproductive life. And then we add PMS and the gynecology difficulties that many women face, but where we see that women with ADHD, actually 45 or 46% of women with ADHD report symptoms of PMDD, as compared to 3 to 7% of the general population. So again, a vulnerability there across the adult life. And then we see when they get parents, they experience much more parental stress. No surprise, because being a parent entails difficulties sleeping, having time to set the routines around diet and exercise and all the things that is so important to manage your ADHD life. So long story short, or long story long, there are a lot of, when you put the lifeline here for girls and adult women with ADHD, there are so many like indicators on this lifeline where we, from the healthcare professional, could support them better, and where we miss them and fail them. So that is something that is very, very vividly described in more and more research today.
So is it fair to say that the girls, we're going through adolescence, are coming to the attention, they're seeking help often, but and what they're saying and what they're describing and how they're expressing themselves is misattributed to something else. Yeah. They're not silent, but we don't know what to listen for. We meaning the general medical and psychological and school counselor and parental community.
That's a great way of framing it, I would say. And when people criticize me for talking too much about female ADHD and talking too much about ADHD in general, I usually respond with, but they're your patients anyway. So you might as well put this variable into the equation, because then you have so much better chances of treating their blood pressure or their depression or their pain condition or whatever if you add this. Because if you miss that aspect of it, you can look at our latest study. We call it Time After Time, and it's a horrible description of a Swedish population-based study where we see that women with ADHD, 5 years before they get their ADHD diagnosis, they are ping-ponging around in the healthcare system. They're everywhere. And they are diagnosed with pain conditions, with chronic fatigue, with fibromyalgia. They're diagnosed with IBS, with all these symptomatic difficulties and problems. They're also treated with all the medication that we have in our toolbox. So they're overrepresented in every aspect of the pharmacological groups that we have. So huge polypharmacy, huge multi-morbidity, and huge healthcare utilization. So they consume 10 times more of the healthcare resources compared to a same-aged woman without ADHD. 10 times more. And you know what the first thing that they say is, when we ask them in qualitative interviews, the first thing that they say when we ask them what is the biggest problem with living with ADHD as a female, they say, I get no help. What, no help? you consume 10 times more healthcare visits than other women. And you say you would get no help. That's not true. And then again, both sides of the story is true. And you were talking about that before, how inadequate we can feel as healthcare professionals when we meet a patient who is not, we're not on the same wavelength here. And maybe when she comes to you already, she's all these negative experiences of previous healthcare visits where you maybe you have to spend like a half an hour of your appointment just to apologize about all your colleagues that she's encountered in the past, and try to build or rebuild the trust for this relationship, because going forward this will be a collaboration. So getting an ADHD diagnosis is not a free pass or anything. It's actually where you can start taking more responsibility for your own health situation and different facets of your problems. And so this is a serious thing where we actually must be mutually invested going forward, I think.
I'd love to get that study. You said it's time after time. If maybe you can remember to send
Yes,
that to
I
me.
sent you the link. It's in the Journal of Child Psychiatry and Psychology, DCPP.
And that's what year was that published?
So now I would say 2 years ago, 1 year ago,
Okay. Yeah.
when or something. Yeah, I'll send the link.
And,
You can put it in the notes for the episode.
and they bounce around that 10 times more healthcare. I heard that you share that at AppSard, and that is qualitatively what I've seen within this. And I resonate with comments that you have received about why do you keep talking about it? I wouldn't have to keep talking about it if people didn't have spent the last 20 years or more, because if you're 55 years old and you've had 20, 30 years of complaints of all of the things.
Yeah.
And I had a very pleasant, we can talk about this, but I have patient stories where the doctor said, you have to stop looking for answers. And the classic is they check SED rates and ANAs and CBCs, and they maybe saw the rheumatologist who said you're fine, or you might have fibro and nobody knows how to treat it, or chronic fatigue. And then you just have to ask that. It sounds more and more education and understanding. Obviously, that's why I try to get the message out with the podcast. I work with medical students who see me and residents and other clinicians, so more and more can have this in their framework of understanding it. I'm guessing for you, as it has been for me, when someone gets that recognition and the diagnosis, there's often that relief, and then there's a grief and a lot of emotions. The patient who recently said to me, or she said, my last doctor said, stop looking for answers. And she just wanted to discuss whether a back injection would be helpful for her chronic pain that's been going on for 10 plus years, and whether an injection. And I started talking, and she was referred by a friend who said, you should listen to Dr. Lenz. He's a good guy. And so she had some hope. And I was just listening to her story, and I wasn't dismissing her. I was just sharing her story and listening. And she said, do a lot of people cry when they see you? Because when you see multiple doctors and you're socially aware, which women are more socially attuned than men, you go, I have to sort of pretend I'm not in distress because they will start to characterize me as a hypochondriac. I don't know. What are your thoughts on that?
I just completely agree with everything that you say, and that there seems to be this, I'm not sure what the English word is, but there's like this battle of prestige in these meetings, where it seems like for some of our colleagues, it seems so important for them to say things like that, stop looking for answers, and that it's almost like, can I mention your president? It's almost like this authenticity, this kind of impulse to always have to say what's on their mind, while when you meet a person and start listening to what they're actually saying, you realize that they're not craving, or they're not, what do you say, they're not demanding certain kind of interventions or certain kind of of answers, but what they really want to do is they want to check in and see if what they're doing is actually, am I going in the right direction? And these thoughts that I have about my suffering and my pain and is that kind of, does it resonate with anything that you say? And also I feel like some of our colleagues, they feel that not saying exactly what they know from the books from med school and where the knowledge on their horizon is at the moment, not saying that out loud to the patient is resigning their medical authority. And I just don't see it like that, because we have to be extremely humble, I think, to what we don't know. It's way more, and I think also that comes with age in this profession, that I was so much more sure of things 15, 20 years ago, because it's said so in the books. And then you meet all these patients who doesn't fit into that norm at all. And then you realize that you have to be humble to all the things that we don't know. You don't have to resign your medical authority. You don't have to treat people with medications that are not proven or evidence-based, or you don't have to do that, but you do have to listen, and you have to make sure that the patient that you're talking to feels that she has been able to and allowed to share her part of her worries and how she views her situation. Because if you interrupt that, then you will have a patient who leaves with a feeling that Dr. Skoglund or Dr. Lenz, if they just got this last piece of information, they would probably have come to another conclusion. And this kind of fosters this insecurity in the patients that keeps, I think, that you have to, maybe I should just seek another professional just once more, just to make sure that, because I don't feel that he or she understood exactly what I was talking about. So I think it's so important when it comes to these complex situation and suffering that and so many of our common patients actually experience, to listen, as you say, and to make sure that you have collected the important part of this woman's history, that you can reflect that you summarize how you have listened to, what you heard, and say, did I get you? Is this what you mean? Because when you do that, in my experience anyway, that is the first step of the collaboration, where I'm actually allowed to present my medical authority here and say, but you know what? All the things that you say, it makes so much sense, and I emphasize so much with that. But you know what? In my book, there's yet no explanation to that. That sucks. I would be furious if I were you experiencing this and I came to a doctor and say, but if you trust me that I know my shit, then that I know that I would tomorrow, if there's new evidence, I'll come with that to you immediately. But today there's no. So what should we do? You need to have a quality of life. You need to do, what should we do? Because there's no operation, there's no surgery, there's no medication that I know of. I will think about, maybe I should consult some of my colleagues, that maybe I should do that, but this sucks. But I'm pretty sure that what you are experiencing now, we're not there yet. Science is not there yet. So what should we do together? I will not abandon you. Because that is also something I think that you fear, that if this is not an actual diagnosis or syndrome or something, or then who will help me? Because then there's no doctor for it, then there's no healthcare for it. And so I think we can do so much more if we are humble to the fact that there's more about human nature that we don't know and that we know, and still we know a lot, right? We are professionals.
Yeah. And getting back to the ADHD part of things, it turns out that there's a convergence and overlap of so much with this, and the impact of recognizing that there was an ADHD occurrence with this, and the impact of treating that and in a comprehensive way can have a profound effect. And just keying in to listen for those factors
Right.
and know what to ask asking the right questions from a medical detective standpoint. Can you talk a little more about the role of hormones and how they impact ADHD? They do impact ADHD. And another question with that, you said this at the conference in a sentence. You said it's that PMS and PMDD, if you look at those symptoms, they really overlap with what we'd
Yeah.
see in ADHD.
Yeah.
So whatever you want to take first.
No, so I think that's extremely interesting. So we can go for the PMS, PMDD part and the overlap first, because when we look at the screening scales for PMDD, how we actually diagnose that, looking at those, I think 17 or 19 questions or something like that, all of them are questions that our ADHD patients or female ADHD patients actually describe. So the overlap is huge. And the unfortunate situation now then is that most of the research is done on males and more specifically prepubertal males. So there are no hormones, the wrong hormones or no hormones. And when we look at girls and women and we factor in the hormones, we can see that many women with ADHD do experience worsening of their ADHD symptoms in the luteal phase. So the period after ovulation, where estrogen levels sink a little bit, decrease a little bit, but is on a stable level over the 14 days before the next period, and where progesterone levels actually increase across this period. So in that period, many women do experience worsening of their ADHD symptoms, but that is the same period where women without ADHD also can report PMDD symptoms. So is this worsening of ADHD or is it PMDD? Today, no one knows. One hypothesis is that women with ADHD are more vulnerable towards hormonal change. So they are like the ADHD deluxe or PMDD deluxe in that sense. But it's also interesting because back to your other part of your questions, where we know that hormones like estrogen are potentiated or potentiate dopamine. So dopamine is the central neurotransmitter when it comes to ADHD. We think that it is dysregulated and that the ADHD brain, for some reasons, react a bit differently to dopamine release. And we know that a lot of the things that we know about ADHD, we know from how medication, central stimulant medication for ADHD works. So that is actually how we came to describe ADHD based on how central stimulant medication in some boys, kids, seemed to decrease hyperactivity, impulsivity, and increase in attention or increase attention. So we know that central stimulant has the effect on this increasing effect or stabilizing effect on dopamine. And then we know that estrogen potentiates dopamine. So in the period or in the parts, phases of the menstrual cycle where estrogen levels are high and estrogen is the dominant hormone, we see, and we don't know this because there is almost no research done, but anecdotal evidence and clinical experience say that ADHD symptoms for many women seems to be more under control in the period of the menstrual cycle before ovulation. And then you have ovulation and the estrogen levels decrease, progesterone levels increase, and then you don't have the same effect of your ADHD medication because estrogen is not there to potentiate the medication effect. And yet another interesting thing about this interaction between hormones and medications and ADHD symptoms are the days around ovulation in the middle of the cycle, where the increasing estrogen levels in the follicular phase trigger ovulation. Around those days, estrogen levels are peaking. And many women with ADHD say that either that they really find a little bit of relief from their ADHD symptoms and their mood symptoms there. But yet another group of females with ADHD say that they get increased impulsivity, that they feel this racing thoughts and that they get all these crazy ideas about what they should do when they get really impulsive, wanting to drink alcohol, go out partying, have sex with people, drive really fast in their car, shopping online, doing all these irresponsible things that, of course, will have effect on the rest of the cycle. So they're in this visual cycle where also when they are on their stimulants may further increase that kind of impulsivity that they experience. But this is very individual. So it's not all women. And we all know that ADHD is so heterogeneous. So you can have this more like inattentive form of ADHD where the increased levels of estrogen actually is a very welcome relief from a dysthymia that is laying like this on your entire mood and functioning. Whereas you can have this more impulsive, maybe hyperactive form where you get really in trouble because you can manage the days where you are in balance with the hormones, but when the hormones are so high and where the estrogens are so high, you really cannot tip over the threshold there. So it's really interesting, super individual. And then we tend to say there's no research, so we can't do anything about it. But we can, because we can track our own cycle. And you can ask your patients to actually start to log and track their symptoms in relation to their menstrual cycles. We can there's so much information in the hormonal fluctuation that is extremely important for our medical decision making. Not the least to say that you can cause extremely serious side effects if you don't realize that the medication effect can be so much higher or potentiated by hormones.
Hormones make a difference. In clinical experience, it was talked about at APSAR, but what is the clinical experience when you're and colleagues who treat girls and women who are having their periods on adjusting the stimulant dosing? What impact do we know from anecdotal and clinical experience? And
yeah, so there's only one small Dutch study with 9 females where the researchers increased the dose 30 to 50% in the luteal phase, where all the women experienced better ADHD control, and where they all decided to continue with this flexible dosing after the study, and where the side effects were reasonable and no adverse or serious adverse effects reported. So there's this pilot study done, and that is mirrored in what we see very much in our clinical experience. However, what I would say is that I am often surprised how much individual variance it is in this reaction to hormones. So we're far from, again, we need to be humble because we're so far from understanding why this woman reacts so positively to estrogen, but so negatively to her endogenous progesterone, but she can really answer well or respond well to synthetic progesterone. And not all progestines, like the synthetic progesterone, are equal. So there are on a scale from very male, like androgen progestines to more feminine progestines. And again, we don't have this prediction model where we can say that, oh, I guess you will answer perfectly on this or that. So we have this, it is like still a trial and error. And again, back to what we were talking about before, then you need to have this collaboration with your patients, and you need that your patients has a confidence in what you're doing. If you have an a patient that doesn't feel safe with what you do and what you know, and that you trusts you, that becomes really problematic to tailor this medication, because there's so much we don't know, and we have to rely on individual measures in this sense, or both when it comes to tailoring hormonal contraceptives, hormonal PMS, PMDD treatment, but also ADHD treatment with central stimulants in relation to the individual hormonal status.
Yeah, everybody's an individual. I talk about with patients, it's like getting a pair of glasses. I don't know what prescription's going to work. A stronger prescription doesn't make you see better. It may be more frustrating. And so we don't know ahead of time. I say if you have your identical twin sister in, I can have a good guess that what's working for her will work for you if your sister, but then sometimes there's so many genes that are involved in this, and half are from mom and dad. So you can have different combinations. Both parents can have ADHD, and all of that gets mixing in. So you don't know, and you have that. And we say sometimes we have to do these adjustments, and having that ahead of time and what to look for along with that. One, you hear this a lot. I've heard this many times. I had been to a doctor before, and I brought up ADHD, and they asked how my grades were in high school. And I said, I got all A's, and they said, you can't have ADHD. Can you speak to that?
Yeah, I have ADHD and I have a PhD and I'm an associate professor. So I guess you can have it. You can have perfect grades. It comes to a cost often. And I would say that women, we see that girls at an earlier age seem to understand what people around them are expecting from them. So in one sense, we say that often. So, they mature much earlier. And they do in some senses. And then the boys have other skills that mature earlier than the girls. But it seems like on a group level that girls understand earlier what is expected from them. And I can really relate to that. And also that if you come from a certain background where school is important and where you are like taught that, then you will put all your energy into that. And you will find ways often around this, but it comes as a cost. And these strategies are often really draining of energy. So you have to often, when you talk to girls that are actually doing pretty well in school, they are cutting off other things from their lives that their peers can actually manage to do pretty well in school and also have soccer practice or and also have friends and also be off during the weekends, while these girls often go straight home from school. Maybe they lay down, sleep for 3 hours in a dark room just to try to revitalize their brain in order to do some homework and then pass out again. And then they spend their entire weekends either studying or just sleeping. So I think what we have to look at when we cannot just disqualify an ADHD diagnosis based on the grades, and because we have to look at the whole picture. And I just talked to a young woman and that I could relate to so much. She's not even a young woman, she's a girl, she's 13, and she said, I have to choose. So I have to choose if I should do okay in school or have a friends. So that is a choice that she's doing when she's 13 years old. And then the choice will probably, because she is a good girl, she knows the expectations of her. And she also wants to because she likes school, because it's structured and it makes sense to her. And she's not that successful in social interactions. So she will probably choose school and she will do pretty well, at least up until the demands are higher and the complexity is higher. And that is not anything to do with her intelligence because she's really bright, but it has everything to do with executive dysfunction and ADHD difficulties. And that's really sad because I've seen these girls over and over again, and then they see or the people around them start assuming that they have autism because they're so socially isolated. They are tortured and struggle so much in social interaction. And it's not typically, when it has this background, it's not typically because they don't enjoy or understand social interaction. It's just because they have to cut that part out of their lives because otherwise they will not manage. And that is not how a life should be spent for a child. It's not. That's not what we intended when we thought that kids should go through school, because there's so much more. School is important, I realize, but there's also so much other things that a child needs to experience and learn and be able to do, right?
And what you just went through is speaks loudly to many listeners
Mhm.
who are women who have gone through this. Probably we know there's high co-occurrence with chronic pain
Yeah.
syndromes
Yeah.
and ADHD, and likely most listeners have never been diagnosed or treated. Although I've heard some listeners share with me that thanks to hearing these connections, they did end up seeking a diagnosis, and how it's had an impact on their life and positively. But like you say, the mental effort to go through the day, it's internalized
Mhm.
stress.
Right.
It's so much more effort, and that is that exhaustion that goes along with it, that fatigue, that all the tests show that everything's normal and you're fine. And then they try
Yeah.
SSRIs because they assume you're depressed, and they're like, I'm not really depressed, I'm just overwhelmed. So adding an element to this, now a woman walks into your office for a checkup, perhaps, and makes a comment that my family thinks I'm getting Alzheimer's. I have dementia because I keep forgetting things. And it's really gotten worse in the last 3 years. Hypothetically, this may be a 55-year-old woman who went through her last period was 2 years ago. And then in talking with her, she might have said, as you take a comprehensive history, tell me about school. Oh, I was a good student. See, my brother, he was big into sports and he was very hyperactive and he didn't get as good at grades. My parents expected good grades and they valued school, so I got A's.
Mm.
But I look back, I always had this chronic low-level anxiety.
Mm.
And when I went to college and got a degree and then married and was a stay-at-home mom and now going through menopause, I feel and then the person starts to cry because she gets teased by her family a little bit about, oh, you forgot this, you
Mhm.
forgot that. Could that person might have ADHD that's been missed their whole life?
You're describing me here. So, but not but 40, 49. I'm not stay-at-home mom, but a lot of the other things. And the most disturbing thing about this history that you're actually, or this vignette that you're describing, is that I went a year. And I've written a book about this. I've written a book about women, undiagnosed women with ADHD, suspecting that they are developing Alzheimer's. I don't know how many times I've written that exact sentence, and I am even diagnosed. And I went a year seeking out my colleagues, tormenting my colleagues, saying, you know what, this is not working anymore. This is something, please scan my brain. There's something very, very problematic going on here. I'm probably developing Alzheimer's. And then Helena, again, my gynecology friend, said, Lotta, maybe you're in menopause. It was like, what? What are you talking about? I'm 48. Yeah, that's worse. That's what it starts. And we did an ultrasound, and obviously, yes, it's, yeah, you're in menopause. Okay, so that figures. So I would say this is a very common story in history, and it is so, we get so little information about this. And even me going through med school, even me doing research on this topic, having people around me every day talking about this, I missed it in myself. So I would say, and many women that I see coming into my practice, and when you actually do then suggest this, because this is also something that is really, it's important to try to keep two thoughts in your head at the same time, because it can also just be menopause. I had my ADHD diagnosis, so I know, and everyone around me knew, that my ADHD was just getting much worse and my medication didn't really work anymore. But for people who are not diagnosed, entering this phase of life where the hormones also affect so much more than your brain, it is pain, it is sleep, it is joints, it is so much of these symptomatic problems that we women actually carry around anyway. So it's again a situation where you risk being gaslighted by the people around you, and in my case, then by myself. So I think it's extremely important to talk about this and to highlight that this period of a woman's life there's substantial reorganization going on in the brain and in the body, and we are preparing for a third lifetime outside of our reproductive lives, and that will be something else in because, and I think so many of us, maybe it's the first time we realize how much hormones actually have impacted our lives and our way of functioning throughout lives. And I think this is for me the first time in my life that I really took it seriously. But looking back, it's been there all along, and a lot of things that I could have probably saved through much smoother if I had taken the hormones into account and factored them in seriously.
I shared your book and I said, go through this diva questionnaire, write down your life story, and go read Dr. Skoglund's book. See me back in 2 weeks. Of course, she said her reading's more challenging now too. So that gets to be
I
another
think it's
thing.
an audiobook because I can't read and I've never been able to read. So I love this AI
Well,
things. So I think, right?
yes, I think I had a patient recently say that they did, and I said, "Oh, was it Dr. Skoglund reading?" And she said, "I think it was somebody else." But
No, they did not want my English. Is I have this. I think listening to an entire book with this accent, I think you'll probably develop ADHD if you didn't have it before.
it is so nice to be hearing these stories. There's so much more that could be said. a couple of things that I wanted to end with. One, you have spoken about bad advice to give
Mm.
about ADHD, and there's maybe 4 of them that I wanted to just quick mention. And if you want to comment quickly, these are things that have effects on lifestyle, it has effects on chronic pain, it affects on things that work for non-ADHD, non-neurodivergent people, but don't always work. And I allude to this in my podcast, but one was eat until you are full.
Mhm. Yeah, that's a very bad advice, right? When you have ADHD and you don't really you pick up on your body's kind of signals in time. And if you're anything like me, you have this huge sweet tooth and you love candy and you eat so fast that it takes you're so full that you're sweating before you understand that you're full. So bad advice.
Next one was exercise when you feel like it.
Mhm. Because probably that's never for most people, and for ADHD the kind of the threshold for that is even higher. Or it's on the on the other end of the spectrum, that it's you feel so anxious all the time, you have this kind of restlessness, and you exercise all the time and you kind of break down your body. So I see both of these extremes actually in women with ADHD, that it gets also obsessive and compulsive in a way.
And that overlaps for many people with chronic pain syndromes. They come in very deconditioned, often
Mm.
very relatively sedentary by the time they get a diagnosis, which is often pretty severe.
Mm.
But most of them, when they were younger, or a high percentage, actually were very active.
Yeah.
Then something happens.
Mm.
They're no longer in the
Yeah.
sport. They're not in a structured activity. Life gets complicated. They have kids, family, or they kept it going and then they got a stress fracture or they had an injury, and for the first time in their life they're not working out 2 to 3 hours a day,
Mm.
and then that, like a little duck treading water to keep afloat, suddenly starts to sink.
Yeah.
Next is, here's another one: have a drink, and we're not talking about a healthy smoothie with vegetables and greens,
Mm.
but have an alcoholic drink and just relax a
Yeah.
little bit.
That's also an awful advice. And as we talked about in the beginning, I come from the addiction field into ADHD. So the overlap is huge. But there's still so many women trying to keep it together, looking so organized, looking so put together in their everyday life, being appointed project managers at work because you're so structured. But that is basically just trying to keep the chaos inside in some kind of order. And then other people assume that they're over controlled, and maybe they are in some way, but the underlying chaos is the thing that is threatening. And then providing the advice that someone should relax by drugs or alcohol, that is one of the worst advice ever, I would say, because what you really need is someone to actually relieve you of the responsibilities so that you can relax, not drag yourself to it. So bad advice, but common, I think, because people see only this very tense woman who is overstructured.
Yeah, and that's often when you sometimes do the initial ADHD World Health Organization version 1.1, talking
Mhm.
about organization. On the surface, they say, "Oh, I'm very organized.
Mhm.
I'm very organized." And again, the myth, like you can get very good grades
Yes.
and all of that. You can, on the surface, be organized, but then when I like using the diva, because then it dives into the
Exactly.
effort behind that and the exhaustion that goes into it, and getting that narrative. And the last one is stay in bed until you feel rested.
Yeah. Bad advice. Again, at least for me, I can stay in bed 48 hours. It can be so difficult to get started and then to stop. So it is this gearbox of the brain that is not very well smooth or oiled or greased or whatever you say. So you have to understand that about yourself, that there is some things that you just need to decide. And it feels awful and it's really unfair. But if you don't discipline or disciplined around some things and not everything. So I'm not talking about building up this tension in life, but just some core values where you have to keeping a regular schedule around sleep is really important, because otherwise your gut feeling is not going to tell you when to get out of bed and when to sleep. And that's unfair, but that's just how it is for very many people with ADHD.
Yeah, and that's often overlapped so much with chronic pain
Mm,
syndromes, insomnia, and
mm,
poor sleep. It seems overwhelming.
mm.
Exercise, especially in the cold northern climates like we are in winter, when you're on a bike, walking on a treadmill, versus the summer sunshine, getting outdoors, where it's harder to get motivated to do
Yeah,
it. That's why a lot of people who have ADHD may thrive in a military structured environment
yes,
where there's structured exercise and they have that drive to be part of it. They get the stimulation, and then when they're out of
yeah.
structured environment.
True.
So
That goes for school for some people as well. So that the school is actually structured, and that is also something that provide this external structure for many people.
yeah, and actually makes me think of, I had a patient of mine who was a retired carpenter, came in for a physical, seen him for years, and he tested severely depressed a year after retirement. And I couldn't tell because men don't always express emotions the
Yeah.
same way women.
Yeah.
And so I just re-went through the questions. The nurse had done the
Yeah.
screening before I went in, and I said, "Let me just make sure you understood this." And he said,
Yeah.
"Yes." But then I thought, being aware of ADHD, I said, "What was your school like?" I didn't really like school. I
Yeah.
went right from high school into being a carpenter. What did you do as a carpenter? I never was the manager. I never was the
Mhm.
supervisor. I never was the expediter. I just did the work.
Yeah.
Single guy, now retired,
Yeah.
and has nothing to
Yeah.
do. And so
Completely,
it's
yes.
unstructured life. So often that's where retirement may be, where you have this anxiety that
Yeah.
comes, and you have the unstructured life and not knowing what to do.
Yeah.
Here's a quick question. What happens if you fail to treat ADHD in those with depression or anxiety? So if there's ADHD
Yeah.
comorbid and they have symptoms of depression, anxiety, but you fail to treat the ADHD, what is the impact of that?
Well, the most probable thing that will happen is that you don't really get the effect on the on the depression and anxiety treatment. But that is, and that is something that we need to know, that this comorbidity is the most common comorbidity. And sometimes it is a consequence. The depression and anxiety can be a consequence of ADHD, about the failures and the difficulties and the problems that you live with. And then if you don't treat the ADHD, you will never arrive at any symptom relief for the anxiety and depression. But then there are also distinct depression and anxiety, and they overlap there. So if you then treat the anxiety and depression, you may get effect on the anxiety and depression, but you probably not get as much effect on the ADHD symptoms, the core symptoms of ADHD, because SSRIs are not very effective on core symptoms of ADHD.
Wrapping up here, leaving with a positive note. So, what is the impact if we do diagnose and recognize and treat girls and women with ADHD? What impact does that have? If you want to share generally and maybe a vignette of something, how this can have an impact.
I think both you and I, we see that every day, right? We see, you talked about it earlier, the relief, the possibility of or the opportunity for people to actually understand themselves and to take responsibility and ownership of their own lives. So I would say the positive things or aspects of diagnosing ADHD, it's almost unlimited for the individual, for the loved ones, and for the society as a whole, because it relieves the entire system. Because undiagnosed and untreated ADHD is so costly and so detrimental for the individual and for the society. So I would say it's almost impossible to summarize all the research that shows how important it is to get an ADHD diagnosis if you have that, and to get a support and treatment for it. And on the individual level, I see that every day, how people throw off their victimized view of themselves, getting ownership, rising up, and starting living their lives at the fullest. And I think that's a beautiful thing to see. And every time that happens, it feels like it's such a privilege to be part of that. And it's so simple in a way, right? Because it's this explanatory model of how your brain works, and just getting those small keys. And it's fascinating that we're able to do that through just talking to our patients, doing a diva, these small assessments, and then we can actually open these doors into people's hearts and minds, and watch them walk out and start living full lives. So difficult to just summarize shortly what that means. But for so many of the patients and for the girls and women that I have met, it has meant life, and just not a degree of quality of life, but just quality of life.
Yeah, and I think one of the messages too is if you're a clinician, get more comfortable with that,
Yeah.
recognizing it does have a major impact. If you're not, didn't have the training, learn, continue to be a lifelong learner and learn from this and having experts on. And if we can be aware of this earlier in life, if we have these skewed
Yeah.
ideas of what this is, and when the mom comes in and then they have a 14-year-old daughter who says, my daughter's that A student, but struggling with the things you share, I need to bring her in to see you,
Yeah.
Dr. Lenz, because I can see that. And I was a lot like her
Mm.
when she was younger. So for those who want to continue to learn more about all the things you've done, you have a couple ways to do that. At least you wrote a book. You want to talk a little bit about that. And then you also have a website and resources and
Yes.
blogs and any other things you want to say about how they can get connected with more of your insights and wisdom.
Yes, of course, I'm so happy that you have the book there and that there are an increased number of also English speaking people, that because it came out in Swedish in 2017 or something. So for me, it's new, and it's so overwhelming to see how many people that are actually finding comfort and learning from it. So that's great. I've also built an app that's called Letter Life, and that's called letters in the alphabet. So ADHD, ASD. So it doesn't really matter what kind of diagnosis you have or if you have a diagnosis, but it's about neurodiversity and life and being a woman. So there I try to summarize all the knowledge that we have today, update it according to recent research, and also a lot of hands-on life hacks from me and from other users. So building a community of women with ADHD who share insights and knowledge and tips and tricks that have worked for us. And also meeting this need that we talked about in the beginning, that so many women with ADHD feel alone and gaslighted, and not knowing where you find the evidence-based knowledge about your condition. So hopefully people will find their way to that as well. And my latest venture now is to try to build this hands-on coaching tool where we call the squad. So being like a squad, ADHD squad, very present in everyday life, more of a hands-on coaching approach. But I'll get back to that in a year when we have developed more of that.
Yeah.
So hopefully you can find more there on letterlife.se. It's a Swedish site, but it's in English also, and the book from Jessica Kingsley Publishing.
There are listeners from around the world on the podcast
Mhm.
and some in Scandinavia.
Yeah.
And they may see, boy, it's been hard for me to get this ADHD diagnosis I want to recognize. Are you able to see patients? Are you seeing patients, or do you have similar minded colleagues
Mm.
that can see you, get connected to?
Yeah,
And
we do. And that is also, that's my Swedish clinic. It's called Smart Psychiatry, so psychiatry in Swedish. .se again, and there I have a lot of colleagues that are trained in the same way, that we're actually looking at the hormonal perspective and the holistic view, as I know that you are as well. So that is and where we can meet, of course, and we have meetings all across the world in every time zone. And I suck at time zones, but there are applications and support for that. So that's also an opportunity, obviously.
I just have to also applaud the general Swedish healthcare. There's a lot of good studies that are coming about ADHD, autism. There's a lot of great databases, I've been told,
Yep.
that the Swedish are really good at keeping track of records. And
Yep.
so when you have these databases looking at impact of autism, ADHD, and with the ones who got treated and those who didn't get treated on chronic pain syndromes, there are those neat databases. So applauding, obviously, that's a lot of the colleagues that in the extended work doing a lot of great work in the country there.
Yeah, there are a lot of researchers doing great work, and we're so fortunate having these registries in Scandinavia. So it's almost like cheating in that sense, because people before us have collected all this data for us, and we can just use it. So it's amazing.
All right. Thank you very much.
Thanks to you, Dr. Lenz. Thank you so much for having me. This has been a true pleasure.